Hello, everybody. Recording live from somewhere. This is Zach Couples with episode 7 of the Movement Debrief. Welcome, welcome, welcome. Man, I can't believe it's already been 7. Today we're going to discuss a few topics. Here's what they are. Stay cool with the classics, my peeps. Make sure you got your classic skills, your physical therapy skills down pat, number 1. Number 2, we're going to talk about some neurodynamic tweaks and tricks. Basically, how can you incorporate neurodynamics into any movement? And number 3 is going to be checking your ego to help your patients. Before we get into that, a little bit of housekeeping. I hope you guys checked out my blog on Monday on how to deadlift, another movement deep dive. That one has a story. I had to reshoot the video a lot, and so normally when I do like my transcription, I can use YouTube to actually help with the transcription. And for some reason I couldn't that day, and because I could not, I had to like type that blog post up or immediately right away. So I was up really late on Sunday doing that. So please check out zachcouples.com and look out my new blog. I put a lot of work into it. I hope you guys get some stuff out of it. Otherwise, let's get to it. So this first thing, why you got to have the classics mastered. So here's a case, and I got a couple cases that we can talk about that involve this. So I was I was with a friend over the weekend, and we were playing basketball, and she fell and hurt her arm. And she was in a lot of pain, and I was kind of checking things out a little bit, just making sure everything was okay. And I wasn't really, it was a pretty nasty fall, and she was hurting a lot, so I wasn't really sure what was going on. And it was like, well, you're really sensitive. We'll just have to wait and check things out until tomorrow. And it turns out that she was still in a lot of pain later on that evening, and she ended up going to the ER, and she broke her arm. And this kind of made me realize that there's a hole in my game. And I've seen this on multiple times where I'm going back to things I had learned when I was in my residency, in my first year out. And, I think a lot of us get down these rabbit holes in terms of there's a lot of cool things that we're learning in PT. Maybe it's PRI, or maybe it's DNS, or maybe it's FMS, or I don't know, some other things. And I think that in a lot of these cases we go really far off the reservation, so to speak, and oftentimes we forget what it means to screen someone for a fracture, or what it means to perform a neurological exam, which I did probably like 3 times today, or how do I apply the Ottawa ankle rules? Like, these things are important. And while I don't necessarily think we have to run a barrage of special tests when we're working with our patients, we need to know if this is someone we can help or we cannot help. And I think that's really what the clinical examination ought to the first box that our examination ought to check up. And I think, too, with a lot of some of the pain science stuff that we get into as clinicians, we forget that acute injuries happen and they matter. And a prime example of this is when I was in pro basketball. I know we kind of poo-poo imaging, x-rays and MRIs, saying like, well, there's a lot of incidental findings, and there's a lot of people who have these findings and are asymptomatic. Well, when you're around basketball and guys get hurt, it's a different story when you have immediate access to imaging. And it turns out that, like, a lot of the times there's tissue damage when they're hurting. And you have to have a good examination to understand when this is something that you can help or when it's something you cannot. And so, point being by this cluster of stories is make sure you're constantly reviewing your basics. Make sure you know your anatomy. Make sure you know your physiology. Make sure you have a good, thorough, subjective and objective exam to let you know if this is someone who you can help or someone who you can't help. You don't necessarily need to know what's wrong. You just need to know if it's something that you can help that person that is within your scope. So don't forget the classics, have the basics down pat. Second point of tonight is neurodynamics. So I think when a lot of us get into neurodynamic testing, which for those of you who don't know, this is neurodynamics is the ability of the nerves to move. And there's a lot of tests that we can incorporate. There's the slump, where you're slouched like this, kicking your leg. There's a median nerve test, doing that. Ulnar, all these things, and those are all well and good. But I think that those are limiting because I think a lot of times you can see individuals where those tests are not sensitive or they don't reproduce symptoms or they're not positive, but you still have some type of neural sensitivity present. And so I'll give you an example. So I saw this chick and she's got like a little bony doodad going on her thumb right here, and she's getting like some burning sensation and some symptoms down into her hand, and she's also got a lot of neck tightness and pain. And I do my median nerve test and nothing happened, right? It was completely negative. Still had limitations in neck mobility. So instead, she was doing this stretch where she would pull her hand into abduction, or her thumb, and it would get a burning sensation. And so, simple thing I had her do that exact same thing, and I said, move your head to the right. Didn't change anything. Then I had her move her head to the left. Oh, wow, that's better. Interesting. So you mean to tell me that the test that we learn classically to study neurodynamics is negative, but that's a problem. I think if we look back into the classic definitions of neurodynamic tests and what makes one positive versus negative, the biggest key is structural differentiation. And what that means is that if I move something distal and some other movement that's way proximal alters that sensation or mobility, you have to implicate the nervous system, or at least the peripheral nerves. And so we can apply this concept of structural differentiation to any movement. So if, I don't know, like an example I gave was in one of my posts earlier was I had someone who had pain with jumping. And basically what I did was I had them slouch and jump, and the symptoms got better. A slump test or a straight leg raise wasn't going to be enough of a load for that individual to experience pain, but jumping was. So in summation on that point, when you guys want to implicate neurodynamics with your patients, what you need to do is just change something that is far away from the area that they're hurting. So if it's something lower body, very simple trick, have them slouch and then perform the exact same movement. So have them find whatever it is, whatever their comparable sign is that's problematic, and see if slumping changes symptoms in one direction or the other. If it's something upper body, same thing. If you have a baseball player and it's pitching and they get symptoms here down the radial nerve distribution, but it's not necessarily something that is reproduced with the radial nerve test. Here's what you do. Have them pitch and maybe change their head position either away or towards and see if that makes a difference. Then guess what the fix is? The fix would be having them do that movement with the context of the movement changed via doing this, or having them throw at a different angle, or what have you. If you just change head position and then perform the movement, a lot of times that is a phenomenal neurodynamic technique to incorporate with your people. So another thing too, if there's something that's more axial and you're just kind of like, maybe I do have some neurodynamic issues involved. If it's above T8, change arm position, or have them do arm position and then do the movement and see if that makes a difference. If it's below T8, move the leg in some way, shape, or form. So, simple neurodynamic trick, and it's a lot faster than going through these tests. All right, the last one, check your ego. So this is this one's big for me because it's something that I've definitely battled through a lot of my career. I had a patient this week, and this woman has had a lot of knee surgeries, a lot, and she hasn't walked in, I think, like 2 years or something along those lines, and she has a lot of fear about walking, and she gets very anxious about any little thing, that if she's getting any type of pain, is this damaging this area, because she's been through so much. And she was seeing a physical therapist, and a ways away from where I am, and there was this very distinct protocol that the physician had put her through, and that they had planned at this rehab facility. And I spoke with the physician and all that after one appointment, but this woman was pretty adamant about just doing the exercises that these therapists were doing with her. And a younger me would have been like, I mean, this is not a sexy protocol by any means. I mean, this is just a lot of the basic stuff. And you guys know me. I like making things unnecessarily fancy sometimes. And so I've been burned in the past by going against what the patient wants in that case. And so this time, now that I'm a little older and a little balder, I decided to go through with that protocol. And so I've been just doing a lot of the classic things. And the cool thing is she's still getting better, by the way. So it makes me think about maybe I'm not so hot shit, which I know I'm not hot shit by any means. But I wish I could tell my younger self that. Anyways, so I called the physician's office and we talked through some things, and I just give them some of my ideas in terms of what we can do. And they're basically cool with me doing my thing as long as I respect timelines and make sure I don't go beyond the things that would hurt her. Totally cool. And so I have this conversation with the patient, and she's understanding it. She's, it makes sense. And I go through and I do some explain fine, a therapeutic neuroscience education, depending on whose side of the camp you are on. And I talk a little bit about her surgical procedure and all that, and what the following weeks are going to look like. And I did something that is very atypical for me, at least in the past, and that is, I said, look, I have all these ideas that I think we can do to help you, because a protocol is not specific to that individual. It's just something to try to hit the mean of most people, or most individuals. Whereas this woman, I think, could benefit from a bit more of an individualized approach. But I gave her the option, and I said, look, I can follow this protocol to a T, and we can go through this route, and I'm sure you will get results. Or we can incorporate some of the things that I think could help you, and have helped a lot of the patients who I worked with very quickly. And at the end of that, I said, I have no ego. It is up to you. You are in control of your care. This is your show. I'm just the guide. And I told her not to answer me then. I wanted her to think about it until the next appointment. And I don't really care what she says in terms of her answer. I don't care if she wants to go that route or if she wants to go with what I have to do. What I care about is that this woman is finally getting some sense of control in her life. She has some say in what's going on because she's been through a lot and she's been bruised and beaten up by the medical system. And the last thing I want to do is have my ego be satisfied at her expense. How many times do we do this? How many times do we do a technique to satisfy what we want when it's something that maybe the patient, maybe it's not even best for the patient, or maybe it's something the patient isn't 100% backing? How many times do we do things that push our agenda or push our ego and not do what's best for the patient? And that's something that I think we all struggle with. And it's something I still struggle with at times to this day. And it's something that I'm sure I will continue to struggle with. But what we have to understand is that it's the things that we do for our patients are bigger than what our letters tell us. And they're bigger than what our beliefs say and what our biases are. It's bigger than that. It's about them. It's about getting them better. And it's about giving them ownership in their care and helping them get back to where they need to go and what their goals are. And I think we'll call that it for tonight. So thank you guys for tuning in. I'm excited that we have 5 people listening to me. Well, not 4. And I saw 8 a few times, so that's good. Guys, if you want to follow me, go to zachcouples.com. That's my website. Check out my blog that I did on Monday. I also, if you sign up for my newsletter, you'll get a free acute to chronic workload calculator. I'm going to talk about this at some point. I'll probably write a blog post about it. But if you guys aren't following Tim Gavitt's work, you're behind the times. Like, this stuff is legit. And I have a calculator that helps you guys better incorporate that into your practice. So sign up for my newsletter. You can also follow me on Facebook /ZCouples. You can also follow me on Twitter. My handle is @ZCouples. Hit me up on that Instagram. I put up hiking pics, and now I'm putting up some cooking pics because I do more of that now. And that's Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And then, of course, follow me on YouTube. Just look up Zach Couples. I think my / on that's Couples Performance. Otherwise, you guys stay classy, keep it real, but not to the extent where things go wrong. And I'll see you next time. Deuces.